Well, good morning, and again, thanks for having us. I think you know me, and I think you know Tom uh, from Tampa. We're going to um, proceed with a talk on ctDNA monitoring and gynecologic cancers. We formatted this talk to be CME compliant, but it is not a CME talk, so there's no credit on this. Um, I was just thinking about, this topic I'm bringing here. We started in 1994, and this has been kind of a laboratory for new ideas. When you think about it, we always have had this meeting after ASCO and after SGO. It gives us a forum to talk about what was presented because we didn't have time to talk about it at SGO and ASCO. We brought previous presidents and previous speakers from those meetings here. And we presented a lot of new ideas here, largely through empiric observation, retrospective science that have turned into standards of care. We converted from, first of all, Jimmy and I were talking in 1993 and 94 about why we needed to take lymph nodes out in endometrial cancer. And then it went to robotics early on before the rest of the country had done it. And then it was how to do sentinel lymph node mapping and parodic nodes. And now, we're talking about clinical trials. We have the best of GOG here. And I think this will continue to be a kind of a living, learning laboratory of new thought and debate, and I hope it stays that way. So with that thought in mind, we're going to talk about ctDNA monitoring, and we hope to have some time for Q&A. Tom is going to start us off. And I did throw 3 more slides in, and when we get to them, I'll just interject because you haven't seen them.
So as most of you know, I am very electronically poor. And Bob wanted to know where my computer was, which is up in Tampa, New York.
Is this not working? So these are our disclosures, which I should have shown you. We want to thank Natera for support of this program. There, here's the intro.
I can go for here. All right, so what is ctDNA? What it really allows you to do is have a window of what the biology at Chuva is, and it uses mutational profiling. I'm going to argue you can use it for early detection. They talk about MRD. I'm going to tell you, I think it's going to improve our treatment for patients, guide your therapeutic decisions. And I'm going to argue that it's ultimately going to direct where our trials in the future and science should lead. Now, I'll actually interject that after you get through talk. Okay. So, circulating DNA, ctDNA, is actually tumor DNA. It's small fragments of DNA that's released in the blood. It's a blood draw, so non-invasive. And it tells you a lot of times the dynamics of what's going on in that patient. And if you think about trophoblastic disease, when you have some patient trophoblastic, it is intrusive, not HCG normalizes, where that normalization, you still have 10,000 cells circulating. This is sort of on the same principle. Half-late to short. Now, everybody knows we have new custom coming out for colorectal cancer. It's a blood test. That is a liquid biopsy. What they have is a series of small fragments of DNA that they generally see in colon cancer. Pick a blood test from you and they see if they can determine the DNA for a colon cancer. Cell-free DNA is actually extracellular DNA. That's from normal cells. Circulating, am I good or bad? Not close enough? All right. All right. Circulating ctDNA is actually the tumor DNA, and it's specific for that patient's tumor. So just because you have a serous cancer, not all serous cancers are the same. So it's specific for that tumor. We're talking about minimal or molecular residual disease. That is a tumor burden detected before you can detect anything radiologic or clinically. Is it a new concept? Yes, since 1948. So 79 years ago, somebody thought of this and actually succeeded. Unfortunately, it's taken everything in time to actually come up to where in 2008, we actually get circulating mutational DNA that we can detect within our bloodstream. In 1994, they were looking at RAS mutations. So not a new concept, but I think what we're currently doing and where it's going today is going to be very important in where we end up. So what's tumor-naive MRD assays? That's basically a non-personalized, it's plasma only, and you're detecting cDNA and it from a tumor, and it can give you an epigenetic signature. You can look at methylation and other signatures. When you look at tumor-informed MRD, you're looking at a tumor from a patient. They're sequencing that tumor. They're getting 50 sequences, and of that, they take 16 sequences, and every time that patient comes in, that blood test will now be specific to that patient. So you're going to say, where is it in the guidelines? Well, as of 2025, NCCN recommends for colon and rectal cancer that we're going to use this for monitoring. Merkel cell. Anybody know what Merkel cell cancer is? Jimmy Buffett, right? So it's a neuroendocrine of the dermis. Little purple lesion, doesn't respond well, but it's definitely, that's how we're going to follow this tumor. You got the B-cell lymphomas. It's recommended follow them for PET-positive patients. Japan has actually come out and said colorectal is recommended for testing using MRD. Is it used in GYN oncology? How many people in the room are using it? So most, I would say most everybody. Does it really fit the guidelines? Do we have guidelines? Well, SGO recognized that it may be useful in select cases. I think it's going to become more than useful. I think it's going to really direct where we're going. There's a study in Vigor. They looked at patients with bladder cancer, and what they did is they follow ctDNA testing. And I think this is going to become the theme through the whole talk. So when your ctDNA is positive, even if you don't have radiologic confirmed evidence, you have disease. When you have ctDNA negative, it's basically an observational. Does ctDNA negative guarantee you don't have disease? Not exactly, but it's probably the best we have at the current. So in this study, they looked at the ctDNA positive bladder cancers, and they put them into treatment versus what normally would happen with an observation. And what they found is the patients that had treatment, statistically, they had an overall better survival and overall better disease-free survival as well as overall survival in the patient. So I think it definitely will improve the patient outcomes.
These are the slides added in. I'll just run in.
I don't remember seeing.
Yeah, I don't remember seeing that one. So
Short time lead.
This is presented at ESMO, of course, in Madrid in 2023. It's from MD Anderson Houston in colorectal cancer, where they were surveying their follow-up patients with ctDNA. And so patients had, you see 847 patients, a large observational study, stage 1 through 4, surgery, neoadjuvant chemotherapy, adjuvant surveillance, and they got ctDNA on these patients. Next slide. Radiographic disease was identified in about half of the patients who had a positive ctDNA when they published this report. And next slide. The whole point of this was early detection of recurrence of disease. The majority of these patients, 82%, had oligometastatic disease, which was in at least 52% of these cases amenable to surgery with liver or lung resection. So the theme in this observational study was really early detection of oligometastatic disease. Geez, doesn't that sound enticing, since we now operate on oligometastatic platinum-sensitive disease? Next slide.
All right. So for ovarian cancer in monitoring, what they looked at is stage 1 through 4 patients. They broke them down into pre-surgical specimens. They broke them down into post-surgical, and then for surveillance. And again, I'm going to come back this sets up the theme for what we see in most of our trials and everything we're looking at. The B and C cohort, cDNA was only detected in patients who relapsed. It's 100% sensitive. If you have cDNA positive, you have a relapse, even if you cannot see it radiologically or on examination. It's a strong predictor of where that patient's going to go. And you might argue that might not have any benefit of treatment. So when I first, and I get it's 40 years ago, it's basically, and you remember, we treated patients. If you're in Europe, that sent the patient home. If you had a symptom, you came back because it didn't, following CA-125, we always thought it made no difference. Does everybody believe that today? I don't think so. How many of you people operate on people with an early recurrence? So it does make a difference. We're monitoring these patients. So I think this is important. This is sort of going to be a theme consistently through it. If you're ctDNA negative, most likely we can follow you, you don't have disease. Again, it's not 100%. But if you have cDNA positive, you definitely have recurrent disease. And it's going to impact the overall survival and the disease-free survival in your patients. And I'm going to argue that I get the patient in the blue line, we're going to follow them. What we need to look at is what's going on. Why are these patients on the red line? What's really happening there? And you can say, we're going to put them on another trial, but we're not curing these patients. So what do we need to do to study those patients? And I think that's where the trials should really start looking at. And maybe Dr. Anderson can spend a little more time in the lab and figure that out. You're working on it. So the benefit of ctDNA is it's going to give you an earlier identification of a patient who has a relapse. It's going to tell you somewhere approximately 10 months earlier before you can see it radiologically on physical exam. And it's actually more accurate by 3 months or more on CA-125 elevation. So it gives you an earlier marker. Now we can argue, does that make a difference in a patient? So if you have an isolated lesion, you can go after this lesion much faster. And you could say, well, if you have a 1 centimeter node and goes to 3 centimeters, does it make a difference? Well, I don't know. If you have a node there longer, you have a better chance of this thing seeding something else. So I'm going to argue that it probably will make a difference. Many patients have a clinical remission at some level of MRD. So if you remember years ago, we had second look laparotomies. 50% of the patients we found disease. 42% of the patients MRD positive will have positive second look. ctDNA positivity you can detect earlier in CA-125 imaging, 6 to 10 months. The problem is that even if you're ctDNA negative, it doesn't exclude that you possibly don't have disease. It's a pretty good marker. It's highly prognostic, and it definitely, if you're positive, and it's going to be the theme through everything we show you today, it's going to relate that this patient has recurrent disease and will not do as well. So when you look at that PARP maintenance, and I think, 2-3 years ago you presented? And we talked about PARP maintenance and maybe de-escalation. So what they did is this was a retrospective study looking at 53 patients, where you started looking at those patients being put on PARP for the first 12 months and then beyond 12 months. 53 patients, small trial. So it's pre-PARP. We're looking at cDNA detection rate, early PARP and late PARP. And what you're actually showing is those people pre-PARP with ctDNA negative, those patients did very well, didn't have disease. But early on, once you had positivity, what we did know, even on a PARP, these patients have disease. And that's what we're showing here. If you look at ctDNA positive on treatment, we definitely again show that progression-free survival is markedly impacted if they're positive, as well as overall survival in these patients. And this is done longitudinal, that every time the patient comes in to see you, we're getting a blood draw. If you put them on PARP and it doesn't turn around and get better, these patients are going to progress with their tumor. This is landmark.
I think this is where I'll take up. So those were 2 time points on that last slide. If they were drawn at 0 to 3 or 0 to 6, it really doesn't matter when you get your ctDNA. I mean, earlier, you're going to be monitoring them earlier, but it was valid. This is retrospective data, and the study was from University of Alabama. And so it was relevant no matter when you thought, maybe I should get a ctDNA on this patient. If they stay negative, you're in great shape. If they turn positive, they're going to start dropping off on PFS. This is not to upstage Dr. Blakely Chung, who's going to present her poster to you, but I wanted to show you a little bit of this data from our institution, a landmark, meaning first time as a after adjuvant treatment. Again, the same theme. If you're ctDNA negative on the top, your survival is very good. If you're positive, it just drops off quickly. And the second landmark was at 3 months after start of adjuvant therapy. This is the most important data that I saw in this poster that Sophie presented at ASCO a few weeks ago. In the bottom, you see the dark blue. These were patients who entered their remission on maintenance therapy, or on adjuvant treatment rather, with a positive ctDNA above 0.1. All of that, I should back this up again. This is people who entered maintenance, correct, Sophie? Yes. After their adjuvant therapy, 1 to 3 months. But if you entered with a ctDNA above 0.1 was the cutoff, all 7 of those patients relapsed within 6 months. Let me say that again. So you've done your neoadjuvant, your surgery, your adjuvant, you're entering your maintenance phase, a draw within 3 months, positive. They all relapsed within 6 months. This is now a biomarker, I would claim, for platinum-resistant disease. And we'll talk about this more in the discussion, but I think it's time that we make a new definition for platinum-resistant disease and start studying trials in this area and not waiting for people to develop bulky disease, which will be more difficult to potentially control. These were patients who were thought to be in remission. Now, if you entered your remission time with, you can see those light blue lines, less than 0.1 or 0, the patients who'd relapsed were platinum sensitive. It took longer time. So I kind of envision, I'm not a scientist in ctDNA, but I kind of envision ctDNA levels are kind of a function of volume of tumor and metabolic turnover in these cancer cells, how rapidly they're dividing. So I'm sure we can create some mathematical function for that someday and describe, what's going on there. But it's kind of a combination of volume and metabolic turnover with cancer cells dividing. There's apoptosis, cell death, DNA is being fragmented, into the bloodstream. And why do you have positive biopsies on the second look surgery when your ctDNA is negative? Don't have a real explanation for that, but think about when you go in for your after neoadjuvant to do your surgery, you see some tumors that are virtually turning into scar, and other tumors, we now have indices for describing what the chemotherapy effect is. So I think even though they may be subclinical on CT scan, sometimes you really crash the mitosis, going on in these cancer cells. Are not dividing, but you're still going to get a histopathologic biopsy that shows a cancer cell there. So it just means you're on a winning path, is what it means. And I wondered, after hearing Tom's talk yesterday, can ctDNA erase Dr. Herzog's blurry line? I think it could. So there's a few real-world examples placed in here. A 65-year-old 3C ovarian or fallopian tube cancer, XLAP radical debulking up front. She gets her, you can see her profile, HRD negative and CCN1 amp, so a bit of a poor prognosis, PDL positive. She gets ctDNA post-surgery. It decreases on chemotherapy, the first bar there, on Carbotax Bev. She goes on the Bev maintenance. You see the ctDNA creeping up, which prompts a PET CT scan at the point with the red triangle. And in this patient, she was changed to, or paclitaxel, weekly paclitaxel was added to her bevacizumab as treatment. and so you see it crashes the ctDNA down to 0. I don't know the long-term outcome on this patient, but again, the question will be in future clinical trials, can early intervention, now that we have 3 FDA-approved treatments plus paclitaxel Bev, as therapy for platinum-resistant disease, can we start doing clinical trials where we do early intervention based on ctDNA in a CT-negative patient and try to show that we can improve outcomes with improved PFS and maybe even OS? Flipping over to endometrial cancer, of course, it's the most common malignancy. We really don't have actionable blood-based monitoring for endometrial cancer. CM5 is really unreliable. In a real-world observational study, Dr. Resio, one of our fellows, presented at SGO in 2024 to about 1,500 people spilling out into the hallway, the first retrospective look at ctDNA monitoring in endometrial cancer. 267 plasma samples. This was multi-institutional. Patients were followed surgically and monitored with ctDNA based on GOG criteria. We segregated patients into low, high, intermediate, and high-risk groups. We had 9 sarcomas. And again, the same theme. If you had your surgery, these were stage 1 patients largely. If you had your surgery and entered observation ctDNA negative, the drop-off was very low. There are different time points here at post-op, longitudinal, and post-adjuvant therapy in the patients who had metastatic disease, 0 to 6 months. Again, it's the same theme. If you positive is bad, you're going to relapse in the majority of those cases if you follow them long enough. And it's pretty quick. You can see the drop-off is pretty steep. If you remain negative, the drop-off is very low. In stage 1 patients, it's in the less than 5% range. And then we looked at MMR status and P53 status. These were biomarkers for poor outcome for these patients. And the bottom line is you can have the worst prognostic factors in the world, but if you're ctDNA negative, you're in remission. And you can have the best prognostic markers in the world, and if you're ctDNA positive, you're going to relapse. It's that simple. So we use markers to determine therapy, but prognostically, what matters is your ctDNA monitoring. There's another observational study in the literature we found from Europe, which essentially mirrored the findings from Dr. Resio in a small prospective study where post-surgical ctDNA was associated with increased risk of recurrence with a hazard ratio of 3.3 and death about 6. So again, a positive predictive marker in a prospectively gathered series of patients, 36 patients. This is their survival curves, which look similar. Their drop-off, I noticed, in the ctDNA negative is a little advanced compared to ours, but they had many more stage 3, stage 4 patients. DUO-E, you're familiar with a large prospective randomized trial in endometrial cancer with platinum durvalumab, and then adding on olaparib, did prospective ctDNA monitoring in their study. And these were the survival curves for the 3 arms based on ctDNA positive and negative. And again, the drop-off much less on this top curve on ctDNA negative. So with metastatic disease, when you enter your remission time, it doesn't mean that you can't relapse because you're negative. It just means you're in a better prognostic group. You have to monitor these patients, and by monitoring, it's going to trigger your next action of a radiograph of some sort, and it may give you the opportunity to do something about oligometastatic disease. It may not always be surgical. It may be radiation therapy, or it may be identifying the disease earlier and then getting on to the next clinical trial. Another real-world example, a 64-year-old with grade 3 endometrioid. Following surgery, she had 6 cycles of carbotax dostarlimab on Ruby, was transitioned to dostarlimab maintenance. She had progression with a rise in Signatera documented with a CT scan. She had pulmonary findings, and IR biopsy suggested histoplasmosis. She continued ctDNA monitoring. Positive ctDNA then prompted a PET scan on the red arrow. So the initial one was negative except histoplasmosis. And then she had a confirmed recurrence, got EBRT. Dostarlimab was continued after EBRT, image guided to a solitary lesion, and she went to 0. So, absent ctDNA, this patient would have probably stayed on 2 years of dostarlimab and then potentially showed up with multiple pulmonary lesions. We have no idea. And until we study this prospectively, we're not going to know what an impact this makes. But I think it's just inherently intuitive that you are going to salvage more patients if you pick it up early and find oligometastatic, at least improve their PFS. ctDNA in cervix cancer has been evaluated. Dr. Monk is not here this morning. Locally advanced, of course, has a high mortality rate with a 30 to 50% recurrence rate. Imaging, has its limitations. We really haven't had biomarkers. Dr. Monk, was the PI on the CALA trial, which was a negative trial looking at immunotherapy added to EBRT and brachytherapy with platinum. Durvalumab proved not to be an active agent in this trial, but Brad's not here, is he? I always say Brad's one guy who steps in the cowshed and always smells like roses. So he does this big phase 3 trial, and he makes a lot of hay, not on the trial, but on the ctDNA monitoring, and, presented this at SGO. So they had a ctDNA that was next-gen sequenced for the tumor, as well as an HPV primer. So it was kind of a dual monitoring. And ctDNA detection at cycle 3, day 1, occurred about 164 days before radiographic evidence. This is a prospective study. The positive predictive values at cycle 3, this is on the clinical trial treatment, was 61 and 82, and then by the cycle 6, it had improved to 74 and 94. So a positive ctDNA at the end of your chemo RT plus Pembro, if they're on that treatment, is terribly predictive. If you enter your remission time positive, it's imperative that you get another quick eval after 2 to 3 months. And if it's not going down, they have active disease and it's not going to go away. And so you can start looking for where is it and what can you do about it. Is it a parodic node, that was never identified and it's going to start growing? Could you potentially add radiation? Could you get them on an ADC trial, as soon as you can figure out where it is? There are things that we can do, with treatment. So it helps you to monitor that patient and know who they are. And conversely, the patient who enters negative, I check it periodically, but you can rest assured, especially if you had a pre-treatment that was positive, that always begs the question, how many of these don't shed tumor? Most of our GYN tumors shed DNA. I would estimate the false negative rate, though, is somewhere in the 5% range. It's low, but it's not 0. Every test has its limitations. So that's how we think about it. In this trial, it was a negative trial, but again, the drop-off was ctDNA positive or negative. And Brad got a great presentation on it. Dr. Kuhn, a fellow who graduated last year, presented this, I think, last year at this meeting, circulating tumor DNA in locally advanced cervix cancer, retrospective cohort of 58 patients. 3/4 of them were stage 1B3 to 4A. The rest were stage 1A and B. ctDNA testing on plasma samples was tumor-informed. Longitudinal analysis, same story. If you remain ctDNA negative, you're on the top line in blue. If you flip to positive, you drop off pretty quickly. And if you enter your remission time positive, they've all relapsed within 10 months. Longitudinal analysis predicts relapse. This is like no recurrences are seen among the negative patients on no matter when they got their first time point. There's just another look at the same data. Another patient for example, 33-year-old with a stage 1B cervix underwent fertility-sparing management with cold knife cone pelvic lymphadenectomy, presented with recurrence 2 years later. You see the big red triangle. ctDNA was positive. She was started on chemoradiation with immunotherapy, underwent laparotomy, LSO, lymph node debulking with pathology demonstrating a microscopic focus based on imaging, thinking she had, oligometastatic disease, but her ctDNA, you can see, is creeping up. And the positive imaging on the red arrow was a common or parodic lymph node just outside the radiation field. And she started quad therapy with carboplatin, paclitaxel, Bev, Pembro, and went to 0. So again, early intervention. How's this going to turn out for this patient? I don't know. But we can detect disease earlier, and we have effective treatment options now, for patients. So for some of them, it will make a difference. How are we doing on time? Well, we got plenty of time. So this is a provocative patient of mine that I put up to say, I think this is where we need to go in clinical trials. This is a high-grade serous carcinoma of the ovary, stage 3C, HRD negative. She had 3 cycles of neoadjuvant chemo and debulking when she got her first ctDNA draw on the left. She was considered R0 debulking. Her ctDNA is low-level positive, 0.2, and she continues 3 more cycles of carboplatin paclitaxel with Bev. Her ctDNA actually creeps up slightly. Now, these are really minor amounts of ctDNA, and when you get your graph, sometimes they magnify the graph based on where it's at. It looks like, oh my God, but you got to realize that's 0.2 to 0.3, not 300 or 3,000. And I've seen ctDNA levels in the thousands in some people, so these are minor changes. But this patient, because she's rising in her ctDNA, I talked to her about essentially de-escalation therapy, like, let's stop the carboplatin, but let's put you on weekly Taxol Bev and see what happens. She took 1 cycle and then told me she couldn't do it anymore. Her neuropathy was so bad. But look what happened to her ctDNA. So I gave her 1 cycle and then kept her on bevacizumab. Her ctDNA drops by time 0.3 to 0.05, getting very close, but then crept up again while she's on Bev. At this point, she's PD positive, and I talked to her about, look, we can continue this, until you show up with actionable, measurable disease somewhere. Or I said, you are PD positive. And I said I could continue the Bev. And this lady was Taxol intolerant. And this may have been before the B96 data came out, but we were using, in the recurrent setting, what we call the Buffalo regimen with Cytoxan and Pembro at that time. So she elected with shared decision-making to go ahead and start Keytruda. And it creeps up a little bit on it, just a little bit. And these are, again, minor changes, but look what happens over time. And I've seen this in patients who are on adjuvant therapy like Lem-Pem or Pem in the maintenance setting, that they may be drifting up a little bit. And I would caution on immunotherapy, do not make a change based on ctDNA. Follow your radiology. But if you're patient, you think about it, immunotherapy is not cytotoxic therapy. You're affecting the microimmune environment. You're engaging the immune system. It takes time. And as opposed to that taxane, 1 cycle, boom, she was very sensitive to weekly Taxol, which kind of confirms what we know from Aurelia, that that's the most active, agent. So be patient on immunotherapy. Don't get too alarmed on the ctDNA immediately. Now, of course, if it's on a trajectory up that's parabolic, that probably is a bad sign. But we continue this. This lady's been 0 now a couple times, and she'll continue. The question gets to be on this is, when do you stop? And I don't have an answer for that. I'm a little cautious about de-escalation. I would tell you, understanding that you're turning off the cell division machinery, but you maybe haven't cured the patient. There could be a lot of stem cells, that are dormant, sitting there, and it takes time for apoptosis. So I'm a little cautious when I hear people talking about de-escalation, like, okay, you're 0 now for 6 months, we can stop olaparib. And I don't know if that's a great idea. I think that needs to be studied prospectively. If people want to sign up for that trial and it take 1 year versus 2 years, yeah, we could study it, but it takes time for apoptosis. I'd be a little cautious about veering off our phase 3 trial evidence at this point. So, could ctDNA be the ultimate in precision medicine? You know, it's a pan-cancer decision-making tool. Um, I haven't always been getting a level at diagnosis or pretreatment, but I am doing that more and more because I really want to know what happened on the initial treatment rather than wait until 3 cycles of neoadjuvant, for instance, or wait until after your chemo-RT is given for cervix. I have been getting samples during treatment or earlier so I can get a read on, are they shedding DNA and what's going on. It gives you a little more confidence. If you're only getting an MRD value and it's negative, I would estimate there's a small percentage of false negatives that we can't account for, and so you're not sure you can rest on your laurels when you have repetitively negative, but you don't know where they started. During neoadjuvant therapy, just to assess response, just like we use CO-25 and CT scans, post-surgery to evaluate MRD and guide adjuvant decisions, surveillance for early detection in advanced disease especially, monitoring for resistance to the treatment you're on, and trying to start strategizing what your next plan is. It gives you a lead time, like I say, of up to 6 to 10 months. So you've got some time to be looking profiles over, deciding whether you want to get another biopsy. You don't want to look for another HER2 marker because your first one was negative. It gives you time to do that because you know you're going to need something in the next 6 months. So I'm going to let you summarize, Professor. Talk on that, and then we can have some discussion.
All right. So I think it's ctDNA is definitely prognostic and predictive tool of these patients as we follow them, and I think they should be followed longitudinal. I'm also we are currently following all the patients as soon as we have a diagnosis. As we collect the data, it definitely shows you if you're ctDNA positive, you know you're going to have a recurrence. I'm going to argue that since that ctDNA is positive, we know up to 10 months before you see anything that you're going to detect. Maybe we ought to start looking at this patient population. If you remember Wendelin's talk yesterday, he showed you that U-shaped curve. It came from Gilmore. That was actually our HIPEC data, those patients who recurred early versus late. And the major changes between that two populations is actually immunologic. And that's why when Rob says when somebody's on like the dostarlimab or Keytruda, just because that ctDNA is positive, don't just jump right away. You have to watch it. I think it takes time. And I don't mean this wrong for any of the trials that we put together. Going between using Bev or Taxol or a folate receptor, we're not curing these patients until we can get that immune system to really change. The other thing Wendelin showed you is the difference on the M2 macrophage. So I think maybe as we start looking at these trials, you have a ctDNA positive, maybe we ought to start looking at immunologic markers within these patients to see what it is that we can actually manipulate. So that would be my plug. I think it's important to put ctDNA in our trials. We need to look at the patients that are positive right from the get-go. And I think we need to start not just looking at a marker or receptor within the tumor. Because if you have 80% of a folate patient has 80% folate positivity, 20% don't. So those cells are ultimately going to recur. How are we going to make that a durable response? And I think it's basic. We have to come to ourselves. If you remember William Cooley, he had the Cooley cocktail up at Memorial Sloan Kettering. He actually injected bacteria into the patient's abdomen. They had great responses. He did better with sarcomas than we're doing today. It's all immunologic. And if you think about if you have a lady with a bowel obstruction or a rupture post-op, they survive the septic event, they do better long-term. So I think inflammation is going to be critical. Lipidomics is going to come down into critical. There's a lot of people looking at lipidomics, but I think we got to start detecting these patients early and then start looking at some other markers within these trials. That's the end of my plug.
Okay. NCCN guidelines. Has anybody read the most recent ovary? Somebody on NCCN. Is anybody here on the NCCN guideline committee yet? Still? So somebody put a plug in there that said it's investigational. It could be informative, but they said intervention, should not be done based on ctDNA. So rather paternalistic advice, from NCCN. I think they're just really afraid, that nitwit people like us here in Florida are just going to run away, and start treating patients off trial, because we're just uninformed. But there's always a bit of truth in everything, and I'm not advocating that we make all our decisions. It's just another data point in your data assessment. And when I have docs tell me, well, I just don't know what to do with the information, or I don't, is this is not in the NCCN guidelines yet. I said, well, are you doing CA-125 monitoring? And I said, well, what do you do with that? If you don't want to monitor your patients, you just want to do the Ruston thing and wait till they show up. Okay, I guess, but that's not modern medicine, and maybe I'm an eternal optimist that we can make a difference in most patients. So I think early detection, I assume they're not getting their teeth cleaned either. They're just waiting for cavities to show up too. But I said, early intervention can make a difference for some patients. We can't cure every patient. We know that. And we can't affect a change that's going to make a difference in every patient. It's only through large prospective studies are we going to prove to the naysayers that we're making a difference for a population. So that's where we've got to go with this. I put in the slide, this is just really crazy that I remember this. I've never used this image before, but I looked him up on the internet. Bronowski wrote this book called The Ascent of Man. It's an amazing book about the development of scientific thought. He's a philosopher, scientist, and broadcaster. He's deceased now. He had a PBS series that had 2 or 3 different series or hour-long shows on this, which I don't know if they're even available to find. But his main theme, and it goes from the beginning of time through, I specifically remember Galileo, but even before that, about development of human thought and understanding science. And what he really calls for is humility, that no matter how many statistical gyrations we do on our data, there's always an element of the unknown, and that we have to understand that and respect it. And I think that's where I'm here, today with ctDNA. There's a lot we don't know yet. There's a lot we do know. But I think what we're showing you, it's a pretty powerful predictor of what's going to happen to your patient. We need to take it a step further now and study it prospectively in trials to show that we can make a difference, in our patients. So thank you very much. So questions. So almost everybody in here has been using ctDNA to some degree? Okay. How long does it take you to realize what I've just shown you? Or are you still just in your early draws of it?
I don't use it.
Well, that's an important point. If all we had to give was Doxil in recurrent ovarian cancer, then it wouldn't make a difference. And, we're in a different era now. Image-guided radiation can effectively treat oligometastatic disease. Histosonics can in the liver. We have more tools in our toolbox, to affect outcomes for patients. So, but that's an important point. 10 years ago, this would be nonsense. Maybe that's part of the reason why it's taken this long to develop. It's like, well, who cares, But now we have things we can do.
Second most stopped because we didn't have effect the therapy. Positive, we had none that work, and so now we have lots of stuff that will keep very hot sequencing. So, in the dogma, 2000 is really, because I think it's a lot well.
I think we'll probably generate data too that, clinical trials are very expensive to run. And I think in the future, when we solidify our information on this, I can imagine, if you're on a clinical trial and your ctDNA is doubled or something, in the first 3 months or something, I'm going to say that patient's off trial, don't waste any more ADC on this patient, for instance.
Your lady did not the right fit ctDNA. When I saw that, I probably would switch because she had for free. And what do you? It was going up then. And it drops weight on Katrina. It was like 0.5, 0.18, point. I'm like, that 0.26, I would have switched. And I said, 3 is trend.
Yeah, and I would on cytotoxic therapy in general, or
You're like, go right.
and I'm going to tell you why. I had a patient on, and again, this is all anecdotal, but I had a patient on Lempem who had a progressive rise like that, but I had nothing else to give this lady. She'd done everything, and I'm on Lempem, and she was asymptomatic, and her scan had either stable disease or no disease. I think, maybe a little lymphadenopathy here and there or something, but it was stable. And I kind of told her, I said, I don't really have another great option for you. Go back to chemotherapy, but I know what happens with it. You're going to get more toxic. And interestingly, she had complained about side effects of Levitinib, and we had dose reduced her down to either 8 or 10. And I guess there's a Facebook website or chat room or something with Levitinib patients. And she said, somebody on the website said they went back up on their dose and they got a response. I said, well, you came down because you were too fatigued and nauseated or whatever it was. You want to do that? She goes, yeah. So we went back to 14. She did fine. And over it took 6 months. It still kept going up a little bit, but over 6 months, it all came down. I don't know if the dose escalation had anything to do with it, but what I think is what's telling me in my mind is that immunotherapy can take time. The whatever's going on in her body, her stress level, whatever, immunotherapy takes time to affect the microimmune environment. And I wouldn't recommend getting off immunotherapy if they're stable on CT scan and asymptomatic.
Was one of the first indications for seeing a error was and then whether they're
Monitoring.
Cancer patient that they didn't drop after C cycles. It's unlikely they got it. See that?
I don't know that there's anything written about not dropping in 3 cycles, but I'm just saying I've seen a couple of patients like this that I've got one patient who's been on this Buffalo trial for 2.5 years, and she's never normalized. It's in the 0.1 to 0.2 to 0.1 to 0.2. It's just bouncing up and down. So we're keeping her stable, modulating the immune environment on oral Cytoxan and Pembro and Bev. I've got her on some Bev too. Bev is supposed to potentiate immunotherapy, right? Breaking down the microvasculature. So I think it's a good idea. But we have patients who are Bev intolerant. You can't use it. So we got 5 more minutes. Who else got a question? Yes.
When you start to do it up, maybe start to draw it up. Have you looked at or thought of looking at like trying to predict what you're like living on that
You'd have to ask Dr. Ahrens on that because I think she's got a database of drawing ovarian cancer patients up front. I'm not sure that level is going to be predictive beyond CT or anything, but probably the rate of drop, just like in CA-125, come up with some inferences maybe.
Yeah.
You might be probably what their ctDNA level is, got more after you see more predictive than whether you're or
Off my call.
We put that data, the numbers right now in both pretty small, but add it.
The surgery doesn't ever come in tumor biology, so yep, sense it.
Any other thoughts or questions? We'll give you 5 minutes back to stay on time. Appreciate the opportunity to share new thoughts and discoveries with you. Thank you.